Okay. Honorable dignitaries,
Recording in
esteemed faculty,
progress.
and dear delegates, a very good evening to one and all. I, Dr. Rishikesh, feel privileged to welcome you all on behalf of the entire team at MCure Pharmaceuticals. We at MCure are proud to present Cardio Colloquium, our highly acknowledged scientific program dedicated to the tools needed to enhance the lives of those affected with the cardiac diseases. I take this opportunity to extend a warm welcome to our respected moderator, Dr. Arvind Das sir. Sir is Principal Director and HOD at Department of Cardiology, Max Hospital, Gurugram. He has fellowship in pacing and electrophysiology from Royal Melbourne Hospital, Victoria, Australia in 1999. Sir is working as senior consultant in Max Healthcare at Saket, Panchashila and Gurugram from 2000 till date. He worked as associate consultant in cardiology in the Indraprastha Apollo Hospital, New Delhi in 1997-98. Also worked as senior resident in cardiology at Batra Hospital, New Delhi. Thank you, sir, for joining. Let me have honor to introduce our expert panelists for today. We have Dr. Kaushal Kumar Harlalka, sir. Sir is senior interventional cardiologist at Goyal Hospital and Research Center, Jodhpur. We have Dr. Jaykrit Bhutani, sir, as consultant cardiologist from Holy Heart Advanced Cardiac Care and Research Center, Rohtak. We have Dr. Dhara Singh, sir, consultant cardiologist at Advanced Cardiac Care, Gwalior. Thank you, sir, for joining today. And finally, I would like to extend a special welcome to all the delegates who have joined today's program. It is an honor to have such an esteemed audience and renowned experts among us. Let me brief you all on the meeting agenda for today. We'll kickstart the program with the session on optimal selection of RAAS in post-MI patients by our respected moderator, Dr. Arvind Das sir. And the meeting will proceed further with the panel discussion where our moderator, Dr. Arvind Das sir, will drive the discussion. I request audience to put their questions in comment box so that we can take up those questions in the end. Now, I would like to invite Dr. Arvind Das sir to deliver keynote session for today. Over to you, sir. I'll stream my screen.
Dr. Rishikesh, thank you very much for the nice introduction. And I would want to welcome my esteemed panelists to this program, and I would want to know their opinion on each and every issue. And a good evening to all the listeners and all the doctors who have streamed and who are participating in this discussion today. It's a very interesting topic, optimal selection of RAAS inhibitors in post-MI patients. And the two things that I want to highlight today about this particular topic is with the advent of interventional cardiology, with the advent of primary PTC and stenting, I have seen in my practice that most of the time we forget about treating LV dysfunction and heart failure because nitrates. One does not notice that it lacks either an ACE inhibitor or an ARB. So that which was a part of the prescription 20 years back. So this topic becomes important because there's a very good role, very major role to be played by RAAS inhibitors in the progressive development and improvement of heart function in the future. That is one thing that I wanted to emphasize. And the second thing, I was just reading and I realized that when we had joined MBBS way back in the early 80s, then there was no ARB, there was no ACE inhibitor. The concept of afterload reduction actually came in the early 80s. So in those times for heart failure, it used to be digitalis and diuretics and nitroglycerine. The concept of afterload reduction was not there. And you fast forward 50 years later, in 2025, it's all about afterload reduction. And these medicines, the ARBs, the ACE inhibitors, they have become the first line therapy in patients in the treatment of heart failure. They have become the first line in the treatment of hypertension as per the American and the European Society. So that is the importance of this subgroup of medicine. And this is what I'm going to highlight, that in your day-to-day practice, as you're seeing more and more patients of acute MIs, do not forget that once you're looking at the improvement of heart function, there's a definite important role to be played by RAAS inhibitors. Next slide, please. which is the angiotensin receptor blockers, the sartans, the telmisartans and the olmesartans. Then you have the ACE inhibitors, in which you had captopril to start with, and then ramipril and perindopril. And finally, the newer generation ARNI, which is the valsartan sacubitril. So you have three definite families of medicines that could be tried in the early post-MI patients. Each have their benefits, each have their drawbacks, and I would try to just faintly tell you which is superior where, so that at the end of the talk we go back with a definite impression as to what should be done in patients who have acute MI and LV dysfunction. Next slide, please. So coming to the angiotensin receptor blocker in post-MI, the early studies were the Optimal study in 2002 and the Valiant study in 2003. Optimal used losartan 50 milligram and compared it with captopril 50 milligram, and it was found that there was no significant difference between the ARB and the ACE inhibitors where total mortality was concerned. In the Valiant trial, which was a large trial with 14,000 patients, it said MI. However, when you give both the ARBs and the ACE inhibitors together, the survival did not improve, but the adverse effects worsened. So you cannot combine an ARB and ACE inhibitor. Next slide, please. So here you can see the optimal trial of 2002, which is optimal trial in myocardial infarction. Slide, if you see the two graphs, you can see the curves are almost identical. There is no significant difference between the endpoint, which is cardiovascular mortality and heart failure hospitalization, between either losartan or captopril. However, numerically, captopril seems to be a little better than losartan. And so ACE inhibitors should remain first choice in treatment in patients after complicated acute myocardial infarction. Losartan, I won't say cannot, but may not be recommended in this population. And you can see that the tertiary endpoint is almost similar. Reinfarction rate is almost similar in both the subgroups. Next slide, please. If you see the Valiant trial, which is valsartan in acute myocardial infarction, you can see the curves, both the curves are almost similar. Whether you are using in terms of prevention of primary as well as secondary endpoints, mortality or overall mortality, cardiovascular death, recurrent MI, or heart failure by hospitalization. So clearly, both the groups behave equally, whether you are giving ACE inhibitors or ARBs. Numerically, it favors the ACE inhibitors a little bit. Next slide, please. Next slide. So coming to the third group of the newer subgroup of RAAS inhibitors, which all of you have been using, ARNI. ARNI is very well known to help in patients who have got heart failure with reduced ejection fraction. But does this benefit also translate into that subgroup of patients who have an acute MI with LV dysfunction? And for that, we have with us the primary results of the Paradise MI trial. Next slide, please. So the Paradise MI trial, the inclusion criteria was acute MI within the first 7 days with LV ejection fraction, which is less than 40%, and or pulmonary congestion. So some element of heart failure needs to be there, plus any risk enhancer, which could be, older age, more than 70 years, or a EGFR between 30 and 60, a prior MI, atrial fibrillation. The major exclusions was if the patient was clinically unstable or if the EGFR was less than 30%. So all these patients were divided into two groups. One group of about 2,830 patients had sacubitril valsartan combination, 200 milligram to a maximum dose of 200 milligram twice a day. The second group received ramipril 5 milligram twice a day. Primary endpoint was cardiovascular death, heart failure hospitalization, outpatient development of heart failure. Secondary endpoint was cardiovascular death or heart failure, first heart failure hospitalization. Next slide, please. When you look at the two curves now, the blue curve is the ramipril curve and the reddish curve is sacubitril valsartan. You can see that numerically the sacubitril valsartan combination has got lesser lesser events as compared to ramipril. 373 events with ramipril. The total number of patients is almost identical in both the groups, whereas 338 events in the sacubitril valsartan group. Next slide, please. However, if you see the entire picture, there is no significant difference in the primary outcome in patients, the event rate, the cardiovascular death, the heart failure hospitalizations. Outpatient heart failure definitely is a little less in patients who are on ARNI, a little more in patients who are on ramipril. So the ARNI scores a little better in prevention of outpatient heart failure. But though numerically ARNI is superior, but there is no significant difference between the two subgroups in in patients who have got acute MI with heart failure. Next slide, please. And when you now compare the adverse event, you can see hypotension is more common with sacubitril, cough is more common with ramipril, as we all know, liver abnormalities more common with ramipril, hyperkalemia more common with ARNI. So the serious side effects of hypotension and hyperkalemia, which sometimes are very limiting factors, are more common with ARNI. In that context, ramipril appears to be safer. Next slide, please. So in summary, if you compare the ACE inhibitor with the ARNI did not result in a significantly lower rate of cardiovascular death, heart failure hospitalization, or outpatient heart failure requiring treatment. The safety and tolerability of sacubitril valsartan in this AMI population was compared to that of ACE inhibitor, but if you look at it closely, you will find the serious adverse effects of hypotension and hyperkalemia was more common in patients who were on ARNI. Next slide. So, once the results of Paradise MI was published, a lot of people started questioning the benefits of giving sacubitril valsartan in the acute MI situation. It was well established that they are one of the best medicines available for treating patients with reduced ejection fraction, uh, which, which, is, which is not of acute ischemic category. Once the infarction has set in, probably it's not better than ACE inhibitors, which was always available with us for the last 30 years. Next slide. Next again. Now, we've discussed the two studies with the ARBs. We have discussed the Paradise MI trial, which is ARNI. Coming to the ACE inhibitor trials, post-MI trials, these were the trials which came in the early 90s and the early 2000s. You have the SAFE trial, the AIRE trial, the TRACE trial, and then you have these really short trials, big population short trials like the Consensus 2, the GISI 3, and the ISIS 4. I'll just touch on a few trials. I think most of us are aware of these trials, but I'll just try to highlight a few important points about these trials. Next slide, please. Survival in ventricular enlargement study. Safe trial used captopril with placebo, and generally you could see that the captopril group showed a 19% reduction in mortality, 25% reduction in recurrent MI. The cavity dilatation, the LV size was reduced, what we call prevention of LV remodeling. And the most important thing is these benefits occurred equally in patients who received lysis plus beta blockers as well as those who did not. So whether the patient was thrombolized, whether he was given beta blocker, uniformly in all subgroup of patients, independent of all the other medicines, ACE inhibitor captopril caused almost a 20 to 25% reduction in mortality and recurrent MI. This was SAFE trial in 1992. Next trial, next study, please. The Trantopril trial, similar, 25% reduction in mortality, 15%. So you're looking at 15 and 25% reduction, a 20% reduction in sudden cardiac death. Next slide, please. And so you have the shorter trials, the 5-week and the 3-month, the ISIS for big population, 58,000. Captopril was effective in reducing 5-week mortality. You see how early the benefits start coming. And the survival advantage appeared to be maintained in the longer term, where we want to emphasize that even if you give captopril for a short period in the early phase of MI, the benefit persists almost throughout life. In the GISI-3, lisinopril was used in 18,000 patients, started within 24 hours. The earlier, the better. The first 12 hours, it needs to be started. And there was a reduction in mortality and the development of severe ventricular dysfunction. And so is the case with CCS1, 14,962 patients tried on captopril. Next slide, please. This is an important trial in acute infarction and ramipril efficacy. You can see that it was a randomized double-blind placebo-controlled trial, acute MI with transient and persistent heart failure. They were given ramipril twice a day, 5 milligrams. And you can see the ramipril group followed up for 15 months showed a 27% reduction in mortality, 19% reduction in the rate of MI and stroke at 6 months. It's difficult to remember these figures, but generally if you round the figure and say there's about a 20% benefit in prevention, in reduction in mortality and hospitalization very early, 4 to 6 weeks, and then up to 6 months also. Next slide. And so with the acute infarction ramipril efficacy trial, they did an extension study in which 603 patients participated in the extension study, and these patients were followed up for almost 60 months. And you can see the graph on the left, see the divergence of the graph in terms of cumulative survival, in terms of benefits. The beneficial effect, and what they concluded with the extension study was that the beneficial effects of ramipril started early after myocardial infarction heart failure and are sustained over 3 to 4 years despite discontinuation of the medicine at 1 year. So you give the medicine for 1 year, you retain a smaller left ventricle, you prevent left ventricular remodeling, and you can see that the benefits are preserved for almost 5 years. And it says that treatment of 9 patients with ramipril for an average of 1 year will result in 1 additional survival to 5 years, which is a very big number. Next study. And then you're looking at now much longer term. So it was 4 to 5 years, and now it's 29 years after randomization. And the survival study of 2021, and you can 603 patients, the same 603, no intervention. You look at the life expectancy or all-cause mortality after 30 years. Next slide, please. And you can see that the median survival in the placebo group was 8.3 years, in the ramipril group was 9.6 years. So you are causing an extension of life of almost 14 and a half months. So suggesting that life expectancy was much improved with ramipril across all comorbid groups. Next slide, please. We let this slide go. Next slide. So what does the result of the AIRE study, the AIR trial, suggest? Number one, substantial survival gains with ramipril treatment for 15 years beyond the blinded treatment allocation. So even at the time, if you have done the trial, even if you stop the medicine, the benefits continue for 15 years and beyond. Overall, for every day a patient received ramipril on average, her life was extended by a further day. And this benefit is most profound in patients who are diabetic, in which case the survival increases by almost 54%. Next slide. So the results, patients with diabetes, previous AMI, previous heart failure, hypertension and angina, each benefited on average from ACE inhibition. Treatment with ramipril for about 1 year, when started early post AMI in patients with heart failure, results in a survival benefit which is sustained over many years and offers on average an extension of life of an additional year. Next slide. Treatment with ramipril for about, so before I conclude, treatment with ramipril for about 1 year, when started early in post-MI patients with heart failure, results in a survival benefit which is sustained over many years and offers on average an extension of life of an additional 1 year. This is the factor that we've been trying to emphasize, that in patients who have acute MI, the three RAAS inhibitors that are available, the ARBs, ARNI, and the ACE inhibitors. The ACE inhibitors have been the best tested. Long-term trials have been done, 30-year follow-ups have been done, and conclusively proven that even if you give the medicine early, within hours of the acute event, and you give it for a period of only 1 year, by which time the LV, you're preventing the LV remodeling, the benefits will continue, and if you follow it over time, they almost add to up to one additional year of survival in this subgroup of patients. Next slide. What do the current guidelines suggest? Next slide, please. So this is in a post-MI state. This is a state-of-art review. Patient comes with an index MI. If you go to the left of the screen, the blue segment, index MI, the first thing that you do is either you take the patient for revascularization, or if there is no facility for primary angioplasty, thrombolize for patients who have got ST segment elevation. Next, early initiation of ACE inhibitors within the first 24 hours. 40% of survival benefit from ACE inhibitor is conferred in the first day, as early as possible. You can start with the smallest of doses. When we were doing our cardiology training, we would start with giving 1.25 milligrams of ramipril. So you can start with the smallest dose and then up titrate depending on what the blood pressure is. It's the first medicine to be started apart from the antiplatelet agents. Try and avoid beta blockers for the first 24 hours because there could be an ongoing heart failure and you don't want to precipitate it further. Next, there should be early introduction of aldosterone antagonist. Benefit is time dependent, should be started within 7 days of index MI. And in this, during the hospitalization period of 3 to 5 to 6 days, reevaluate whether there is a requirement for beta blocker. And if there is a requirement, please initiate beta blockers. Subsequently, the patient gets discharged. It's critical to titrate doses of medications, including ACE inhibitors and beta blockers, to optimal levels in the post-discharge time period, trying to keep the systolic pressure a little over 100 so that symptoms of hypotension don't develop. So after the initial presentation and the thrombolytic or the angioplasty procedure done, please initiate a patient on ACE inhibitors. The earlier you introduce, the better it is. It has in the all the trials, it has shown remarkable benefit. Side effect profile is better than on giving ARNIs, and it is numerically better than ARBs. Next slide, please. So what do the index journals and the societies say? Jack acknowledges the AIRE study, which was presented in Lancet in 1993. And if you look at the boxed red box segment, ACE inhibitor should be administered within the first 24 hours for heart failure in patients of ejection fraction less than 40%. Significant survival benefit, 40% conferred on the first day of treatment. Early initiation is important. We should know the contraindications. If the systolic blood pressure it has to be more than 100, if there is shock, if there's acute kidney injury, renal failure, or drug allergy, you should not give ACE inhibitors. Next slide, please. The 2020 European Society guidelines suggests the ACE inhibitors, and in case there is intolerance to ACE inhibitors, then ARBs are recommended in patients with heart failure, with reduced ejection fraction, diabetes, or CKD, unless contraindicated, in order to reduce all-cause and cardiovascular mortality and morbidity. And this is a class 1A indication. Next slide, please. The ACC-AHA 2025 guidelines released this year in February 25. You can see in high-risk patients with ACS, an oral ACE inhibitor or an ARB is indicated to reduce all-cause death and MACE. Class 1A indication. You can see in this particular chart, recommend guideline, ARNI does not find mention. So even the ACC-AHA recommends that ACS patients with LV ejection fraction less than 40%, ACE inhibitors should be started as early as possible. Next slide, please. So thank you so much. In this presentation, I wanted to emphasize the fact that we should not forget the medical management of acute MI and LV dysfunction, which seems to have taken a back seat because everybody is inclined towards angioplasty and then towards antiplatelets and subsequently quick discharge. Most of the patients are discharged within 24 hours, and even in our hospital after a primary procedure. There is definite role, and it seems to be that there's a resurgence of interest in ACE inhibitors amongst all the three categories of RAAS inhibitors that we have, the ARB, ARNI, and ACE inhibitors. ACE inhibitors have been shown to have the best results with lesser amount of side effects, and there are more number of trials which justify the use of ACE inhibitors in such situations. Thank you so much for listening to my talk. I hope I've been able to convey the message, and I would also take this chance to initiate the panel discussion with my esteemed colleagues. I think if they are here, then we can start the panel discussion. Dr. Kaushal, so this is a question to Dr. Kaushal. In your center, in all patients of acute MI in which you've done revascularization, when, at what systolic blood pressure would you initiate ACE inhibitor therapy? And what is typically the starting dose that you recommend? How do you up titrate? I just want to know what is the protocol followed in your hospital.
Sir, good evening, sir.
Good evening.
Sir, excellent talk, sir, and excellent overview of ACE inhibitor. Actually, in this era of ARNI, in almost all patients, we are going behind the ARNI, except in this subset of acute coronary syndrome or acute MI patient. So, in acute MI patient, especially in initial 4 to 6 weeks, still we are using ACE inhibitor preferably. So, after if patient is not having frank LVF and patient is of inotrope and he is having systolic BP of more than 95 or 100, then I usually start ACE inhibitor. In low dose, Ramipril 1.25 milligram HS, as you rightly said. But if BP permits, then I start 1.25 milligram BID. Initially, if BP is more than 120 or so, and up titrate every 2 to 3 weekly, sir, depending upon hemodynamic and patient symptoms.
Okay. And would you start as early as possible, or you wait for the first day and then you start the ACE inhibitors?
Especially in acute entry-wall MI, because these patients are having more systolic dysfunction and BP usually, if it is good, then I start just after primary angioplasty. In the night after primary angioplasty, BP is more than 100, 110. But if inferior MI, when patient is in hypotension, then wait for 24 to 48 hours.
Okay. Thank you. And now a question to Dr. Dhara Singh. Dr. Dhara Singh, will you switch the patient to an ACE inhibitor if the patient at the time of MI was receiving ARB for hypertension? I mean, that is a very interesting question, because these are patients who are, most of the patients, if you see in my practice, 90% of the patients are on ARBs, only 10% of them are on ACE inhibitors. If one of them were to have a heart attack, would you switch them to ACE inhibitor or continue ARBs?
Yeah. Good evening, everyone. So my answer will be, I will switch to the ACE inhibitors, because even in the optimal trial has failed to show the superiority of the losartan over the captopril. Even the next study, Light 2 study, which was done in the heart failure trial, that also has shown that the ARBs are not better than the ACE inhibitors. Moreover, there is a high risk of sudden cardiac death in the patients who are on the ARBs, like in the losartan group. This was about the losartan. The another drug which is that not much commonly used in the clinical practice, that is valsartan. So if you see the data from the Valiant trial, it has almost comparable data as compared to the ACE inhibitors, but the most of our patients are on the telmisartan. So losartan and valsartan are not that much commonly used as telmisartan, either by cardiologists, maybe by physician, or some the general practitioners also. So the commonly used ARB is the telmisartan. So in the telmisartan on target and the transient trials, both have shown that the ARBs are not better than the ACE inhibitors. So my choice would be I will definitely start the ACE inhibitors. What in my practice I do start with the Ramipril 2.5 mg twice a day if blood pressure permits. So as you have already told, that there is so much safety data, and there are so many positive trials like Save, Air, Trace, Smile, GISI-4, ACE3, and but except the consensus 2, the data on the mortality was higher with the IB enalapril, that they have used the enalaprillate. Yeah. So that was the only one trial which has not shown the benefit of the ACE inhibitors. Otherwise, rest of all trials have shown the benefit of ACE inhibitors after the post-MI. So my current the practice is I always start with the that Cardes 2.5 mg BD. If patient is not in heart failure, then I generally start with the Cardes Meto. that is 2.525 BD. This is my ACN practice. I don't remember any mishappening with the cardiac method 2. Sometimes I have to decrease the next second dose, or sometimes I have to avoid the second dose because of hypertension. That's all.
Thank you so much. That's very good information. Is Dr. Jakirat Bhutani is there or?
Yeah, I'm here, sir.
Okay, good. Okay, there you are. Thank you. Thank you so much. How early do you think an ARNI can be initiated in a post-MI patient?
Good evening, everyone, and good evening, Dr. Das. Your presentation was really good, sir. Very informative and very to the point and very informative. About answering the question, like how early can an ARNI be initiated? I think that most patients with an MI who have a reduced ejection fraction, mostly anterior wall MI patients, they have an ejection fraction of less than 40% mostly. So they don't allow, the blood pressure doesn't allow to initiate an ARNI at when you discharge them even in the 24 hours. So I feel that with an ACE inhibitor like CARDACE, like Ramipril, I think even just giving 1.25 milligrams of Ramipril doesn't cause as much hypotension as does 50 milligrams twice daily of ARNI. So I think it is very safe to give ACE inhibitor right at the discharge, immediately within 24 hours of having an event. You want to save the heart, you want to save the ejection fraction, you don't want any negative remodeling. So I think it is very wise to use the 1.25 mg right at discharge and step up at the next visits. And then at our center, what we do is that we do an echocardiography at a 1 month follow-up. So when you do an echocardiography at 1 month follow-up, and if you still see that the ejection fraction is less than 40% or it has come down to less than 30, then you might want to switch to ARNI. Otherwise, I feel that Ramipril that has the strongest, robust data to support use in post-MI patients. So building dose of an ACE inhibitor is very important post-MI.
So I thought this question was very good because I don't know if there's a specific, a specific opinion by any of the societies as to when you would understand that in a patient who has got reduced ejection fraction, later on in life, ARNI is much better than ACE. But when to switch from?
Yeah, I don't think.
Do it at 1 month, or would you do it at 6 months? Technically, I would personally think that you would give the heart 6 months to recover from whatever has happened and then switch to RD. But I can understand your point that at 1 month you do a good thing, you do an echo and then you switch over.
But that's what that's what I want to say as well, that we find almost no patient that has not recovered at least 2 to 3% or 5% of ejection fraction in all these in the 1 month. Sure that we give a very high dose of statin. We want to ensure that as much as lipid lowering can be done in 1 month, it cannot be done because it is the best time for the patient. The patient is under stress, he has had an MI, and you can give all the drugs. He'll be very compliant with whatever drug therapy you give. So I think you should hit hard and hit fast. So the first month is the best time to hit hard, and we do all this testing like fasting lipid profile, screening echo after 1 month of the event, because if you do it at the time of MI, it will be all deranged. That is why the patient has had an MI. So you want to do all the testing after 1 month, and if the patient recovers well and fine, and if he doesn't, then we step up the drugs.
Right. Thank you so much. Thank you. So now I think it's a open question to all three of you, that in a post MI, sorry, I think did you miss a slide? Is there a slide before this? Anyway, Dr. Kaushal, this is a question for you. Post revascularization, if you find LV systolic dysfunction, ejection fraction less than 40%, but without clinical heart failure in your patient, will you put the patient on ACE inhibitor or ARNI?
I think one thing is missing in the question, that is the time period. That is just after revascularization or after 4 to 6 weeks.
Right.
We know that after successful revascularization, if we have done the timely in the window period, within 4 to 6 weeks, maximum LV function recovers. So if the scenario is there after 4 to 6 weeks, then definitely 4 to 6 weeks, we are going to start the ARNI. But if within 4 to 6 weeks also, definitely ACE inhibitor we will give. But if 4 to 6 weeks, still if it is less than 40% and patient, even if it is asymptomatic, then we will switch over to ARNI therapy.
Okay. So I think similar to what Jakrith had said that
Yeah, definitely.
in the initial 1 month, you would prefer to give ARNI, and then probably after 4 to 6 weeks, switching over to you prefer to give ACE inhibitor, and then after 4 to 6 weeks, switch over to ARNI, which makes sense.
Yes, sir. Yes.
Okay. Next slide, please. So, question to the expert panel. We talked about ACE inhibitor and ARNI. In a post-MI patient, post-revascularization, we come to the beta blocker question, which in the recommendation I mentioned that you should start after 24 hours once you know that how the heart failure status is. In your practice, when do you like to start a beta blocker, and then which would be your preferred beta blocker and what dose? Any one of you can answer that. And is there a role of ivabradine over here? That's a question from my side. Would you prefer to add that in patients who have sinus tachycardia? So what is the normal what is the normal protocol that you follow in such patients? Anyone can take the question actually.
Okay, sir. I'll take the lead here and I'll begin. But about starting a beta blocker, I think that we like to start the beta blocker as soon as the patient allows, the blood pressure allows, and the heart rate allows. Because if the heart rate is already 65, 70, I don't want to start a beta blocker because it further lowers the ejection fraction. And once you go less than 60, it further lowers down the blood pressure. So I think I want to target my heart rate between 60 to 70 beats per minute, and if it is high, and BP allows, you'd like to give beta blocker. And another indication is that if the patient has had a VT during the procedure or in the hospitalization, if the patient has had the multiple VPCs are there or any arrhythmia is there, I would like to give a beta blocker. The preferred beta blocker at the center that I work, we tend to use bisoprolol more than metoprolol. Definitely not carvedilol, but bisoprolol or metoprolol. We feel that the BP falls more with carvedilol somewhere, but metoprolol and bisoprolol is just more selective. So often these patients are smokers and have some, respiratory disease as well. So bisoprolol is a worthwhile choice at our center. And the dose is usually 1.25 mg once daily. The tablet that is 1.25 mg is also scored by some companies like the patent molecule, the Concor. So we use even half of the 1.25 mg Concor in some patients. And an ACE inhibitor and beta blocker combination, I think we use that for discharge at our center. And whenever we want to use that, if we add metoprolol, then we'll just discharge on a Cardace meto, where we give both the metoprolol and reduce the pill burden as well for the patient.
Sure. Yeah. So I think that's kind of very in fact I remember the times. Sorry, I remember the time when there was no primary angioplasty and we would thrombolize the patients when we used to be in medical college, and there we used to give IV beta blocker, 5 milligram metoprolol, and then wait, and then after 5 minutes give 5 milligrams. So in those situations, you're actually giving beta blocker at the time of MI. You're not waiting for 24 hours to happen.
Exactly.
So I think our experience, whatever the recommendation is different, but our experience of starting beta blocker very early has been there for a very long time. And I think it always, I like to see my patient with a heart rate of about 60 to 70. I don't want a heart rate of 100. So I probably would also agree with you that we start beta blockers very early. We don't wait for the 24-hour period to happen. Next slide, please. So question to Dr. Dhara Singh. Do you consider NT-proBNP as a deciding marker for choosing ARNI over ramipril? And how frequently would you use an NT-proBNP in your patients?
Yeah, so basically, I never used NT-proBNP as a clinical marker for choosing ARNI or ACE inhibitors, whatever it is available. So it is what we do routinely in our clinical practice, that is the clinical symptoms of heart failure, like the worsening of PND, orthopnea, or any other exertion dyspnea. We use anti-probenpi when the patient is in the condition we have to admit the patient for the persistent heart failure, or the patient is in the class 4. Otherwise, we always use the drug, either inhibitors or RNA, on the clinical basis only. So because the BNP itself is not that much specific, because we can have the decrease in the BNP when the patient is obese, the patient is on ACE inhibitors, patient on the L-lactone, that is spironolactone, on the some diuretics and the beta blockers also. The alternatively, we can also have the false increase in the BNP level, like the patient is older, female sex, the pulmonary disease, systemic hypertension, hypothyroidism, so many, the renal failure, so many other conditions also. So the anti-probenpi is not the deciding for me to start the ramipril or the ARNI. So I always start see the clinical history of the patients and the echocardiography, whether I go for the inhibitors or ARNI. But in the clinic practice, I have never found any uh, uh, a difference between the inhibitors and the ARNI. Exceptionally, in some 2 or 3 patients, they are doing better with the ARNI than the inhibitors. Even some patient has worsened with the ARNI. So I again to go back to that cardiac matter.
Thank you so much. Thank you. Next slide, please. So again, a question to Dr. Bhutani. Will you start an ACE inhibitor in all patients with ACS, whether revascularization procedure was performed or not, to get the mortality benefits?
I think, sir, the data has nothing to do with the revascularization procedure. So it is quite clear. If the EF is low, we have to give. And if EF is low, if the patient is post-MI, even if you are thrombolizing the patient or doing nothing, I think even if you are just giving heparin or a low molecular weight heparin. So I think I would like to give ACE inhibitor if the BP allows and all those things are there.
Absolutely. So even in earlier days, we used to have captopril. It used to be a 25 milligram tablet, and we would give 1/4. So 6.2. I remember writing that 6.25 milligram 3 times a day and miss a dose if the BP goes down. So irrespective of whether you do revascularization or not, one has to give ACE inhibitors at the earliest. Next slide, please. Okay, so this is a question to the expert panel. What % of your patients tolerate? I mean, this is a question asked about 200 times to me. What % of your patients tolerate ARNI 200 milligram twice a day as compared to ramipril 5 milligram twice a day? Because if you see the comparison in Paradise MI trial, you know, the benefits were 200 milligram twice a day versus 5 milligram twice a day. So in short, I'm just to ask, if you for a moment forget acute MI situation, in normal heart failure situations, what % of your patients are on 200 milligram twice a day of ARNI? That would pretty much answer. I mean, any one of you can take the question, please.
So I would like to say that the only 2 or 3% of mine who are the candidate for the ARNI 200 milligram BID, but they are not taking. I prescribed to them, but still they are not taking because of the dose is too much. So the 100 milligram BID is the maximum tolerated dose. I think it is enough for the Indian population because of the lower BMI and or the other complications like hyperkalemia, worsening of renal function, and the hypertension. So I think the commonly used dose in our setup is 100 milligram BID. I tried to put some patients on the 200 BID. Unfortunately, either the drug is not commonly available or some patients are reluctant to take. So practically no one is on 200 BID, at least in my practice.
Okay, Dr. Kaushal, what about you? Do you have patients on 200 BID?
Yeah, definitely. Around, I would say around my 5 to 10% are on 200 milligram BID. Actually, major bar for this ARNI 200 milligram BID is the cost of the therapy. because they have not reduced the cost of the 200 milligram dose. So major concern comes for the 200 milligram BID. So as you rightly said, if we'll keep apart acute MI patient setting, I think 200 milligram BID doesn't present hurdle in terms of the blood pressure, because patients who tolerate 100 milligram BID, already their BP is on the higher side, like 100 and 120. So we can easily make them 200 milligram BID. But main concern comes practically, that is the cost of the therapy. But definitely, if we'll see the number of patients who are on Ramifil 5 milligram BID, they are definitely more than ARNI 200 milligram BID. But one major hurdle is the cost of the therapy. Because once patient tolerates ARNI therapy for 1 to 2 months, 3 months, 4 months, then EF becomes improved, LV remodeling gets reversed, and patient's BP starts increasing. We are decreasing the dose of diuretic. So most of the time, patients who are tolerating 100 milligram BID, most of them tolerates 200 milligram BID also. But cost of therapy is the main concern in those patients, because 200 milligram BID costs very much.
Okay, thank you so much. Next slide, please. So I think that was a wonderful discussion. Thank you, Dr. Dhara, Dr. Kaushal, Dr. Jagrith. Wonderful discussion. I think we go back before we end the session. We go back with the opinion that in the post-MI state, it is best to start ACE inhibitor because it is backed by evidence. It has to be started early. It has to be up titrated. And at least for a month or two, it needs to be given before we decide to switch over to ARNI or to continue with the ACE inhibitors. And safety profile is very good. So this is a medicine which should come back into practice, because somehow over a period of time, I have seen in my hospital that the prescriptions don't have it because people are concentrating more on ticagrelor and statins and aspirin. So thank you so much. Thank you. Back to you, Dr. Rishikesh.
Yeah, sir, before we conclude and I go for vote of thanks, there are 2, 3 questions in the chat box. So with your permission, can we take those questions?
Please go ahead.
Is it visible to you at the bottom? You have uh, chat function, so where you can click on your screen if it is visible to you, sir.
Okay, yeah. So I can, yeah. So there was one question from the online audience. Want clarity on guideline recommendation as ACE inhibitors, ARBs. There is no separation. As in ACS, ACE inhibitors have better outcomes and evidence. Still, ARBs are mentioned. What is your take on it? Would anyone want to say anything?
Yeah. So I would like to say that the ACE inhibitors, ARBs are separate. They are not the same. So ACE inhibitors has the other advantage, like it increases the bradykinin level. It has better reflex control. It has better control in the autonomic dysfunction, while the ARBs are lacking the others. So I have already discussed that the ARBs increases the sudden cardiac death in the post-MI patients, while the ACE inhibitors prevents. So they are the two different drugs. Maybe you can say on the patient on the hypertension, or those patients who are stable, you can say the drugs are same for them, but not in the post-MI patients. They are labile. They are at high risk of having arrhythmias. Their autonomic function is not controlled. The baroreflex mechanism is not that much controlled. So the ACE inhibitors are always preferred over the ARBs in the post-MI. And I would again say that the ACE inhibitors and ARBs are not the same.
Okay, so and the second question was starting ARNI early in MI patients, how safe it is, as observed hypertension in many patients. So we know that early ARNI should not be started. Even it's not even recommended. In MI patients, it's better to start ACE inhibitor. The third question is, in Transcend trial, telmisartan was not superior to placebo, while in On Target, the result was telmisartan was inferior to ramipril. Can the panel share their view on it?
So I would say that the transient trial, the population was not that much. In the on target trial, they have the data of over the 50,000 population, while in the transient trial they have included only around 5,000 population.
Right.
So yeah, so that was on the acute MI patients. So the basis of transient trial, the telmisartan was not considered as the drug of choice after post MI. So definitely on target trial, the results were almost comparable with the ramipril, but in transient trial, the telmisartan has failed to show the superiority or non-inferiority over the ramipril.
But that pretty much that answers all our questions. Back to you.
Rishikesh.
Yeah.
Yeah, Dr. Rishikesh is back.
Dr. Rishikesh,
Yeah,
back to you.
Sorry, I was logged off due to technical issues. So we are nearly at the finish line, but before we conclude, let's express our gratitude to all those who made this scientific program possible. I would like to express my sincere gratitude to our esteemed moderator, Dr. Arvind Das sir, for delivering the excellent session and driving the interesting panel discussion. I would also like to thank our expert panelists, Dr. Kaushal Kumar Harlalka sir, Dr. Jaykrit Bhutani sir, and Dr. Dhara Singh sir for sharing their knowledge and expertise with us today. I would also like to thank our esteemed audience for their time, continued love, and support for the Cardio Colloquium program. On behalf of MCure, I extend my heartfelt thanks to everyone from sales, marketing, and medical team at MCure who have contributed to this program's success. Thank you all once again for attending and encouraging us. Good night and good time ahead. Thank you.
Thank you so much. Thank you so much.
Thank you,
Thank
sir.
you.
Thank you.
Thank you.
Thank you, doctor.
Thank you all.
Thank you, sir.
Good night.
Good night.
Good night.